All right. Thank you for joining us this evening. This is the first of hopefully many series of free webinars and education that we'll be providing by Carolina Public Health Center. We're a local physical therapy clinic here in Raleigh, specializing in pelvic floor therapy for all genders. And tonight we're going to be discussing what happens to your body after baby and what you can do about it, specifically with respect to the pelvic floor and your core system. Quick introduction. My name is Emily Wegmann, and I'm a mother, a wife, and a doctor of physical therapy with a specialty in orthopedics and pelvic health. And these are my two teenagers, which are exciting and fun to raise. And the oldest is off on a cycling adventure, and the youngest is cooking his dinner right now. So they do mature and grow up a little bit. Today we're going to be discussing a little bit about pelvic floor therapy, and then we're going to learn about anatomy and all those lady parts that maybe you didn't learn or were curious about. Some common problems that occur after baby, but again, are not normal. And then how do we return to exercise and nighttime fun and intimacy? And so usually we do these talks in person. Before COVID, we would go to gyms and people's homes. But since COVID, we've been transitioning to an online format. And we have this little diagram 3D model. And this is actually our clitoris. And in the online image on this slide, this bright yellow thing is our clitoris. So when we think about our clitoris, sometimes we just think about the glands or the head, but it actually has legs that come around the vaginal canal next to the urethra. And we're going to learn more about that organ in just a moment. And it is purely designed for pleasure. It's the only organ in our body that's just for fun. So we should take advantage of it. When we talk about our pelvis and our pelvic floor, we want to learn about what does it entail? What is our anatomy? And the vulva is the outside part. And oftentimes we weren't taught this as in sexual education class or anatomy. And it goes all the way from the mons pubis, that pubic bone area, all the way down to this perineal body and everything in between. It entails the labia majora and minora. And the labia minora and majora come up and create the hood of the clitoris. And so we just see just the little head of that clitoris, but it's actually covered by a fascial hood that when we get aroused, it moves back and exposes the clitoris a little bit more. And then between the labia, we have the urethra and the vaginal opening. And these are distinct areas. And if we look at our little vulvar model here, we can see that the labia come in different sizes and shapes. There's some nice padding and cushion that helps with protection, for sitting against something. And also the hair serves to really protect from infection and bacteria. And then the vaginal opening is just right up here, but the whole vulvar area is here. And so sometimes we get some dryness. And we'll talk about scarring and things like that occur after having children that could use some special attention. So that's a little bit about the outside. And then if we dive into our genitals, the clitoris and the penis are basically, they look very similar, right? So they have a little legs here, they come up and create the head right in here. And this is the part that the clitoris has 8,000 nerve endings. That can create a lot of sensitivity, good or bad, but hopefully for good. And then when it gets engorged, it increases 300 times its size. And this is a fun fact. It never stops growing. So kind of like your nose, it continues to grow. So it never ages. So how awesome is that? So pleasure can last forever. So that's kind of a fun thing. And as you can see, it's going around. This is the opening of the vagina and the urethra. So it's actually going around that whole vaginal area. But really the most sensitive part is the tip. So when we talk about pleasure, this is the area, the tip of the clitoris, that needs to be stimulated. And then we'll discuss the outside. So there are several muscles of the pelvic floor that help with support and function of our organs and our core system. And there's multiple layers. The first layer is called your urogenital triangle muscles, and that's this slide over here. So they kind of look like a triangle here, and they're pretty superficial. They're really designed for going around the urethra, the vagina, and then they interconnect here with this external anal sphincter. So they're sphincteric in nature. So they're going to really close around the urethra to maintain continence, as well as supporting the bladder structure. And they work well with this second layer. You can see this is your, like half of your bladder has been cut. And here's your urethra. And then muscles that go around the opening of the vagina, as well as that urethra to give support to that urethra, which helps with maintaining continence. And we'll talk about that when we talk about stress incontinence. And here's this perineal body, and this really anchors the superficial, the second, and the deep layer together. And oftentimes with child birth, this area gets torn. And so you can see that common anchor point can create some instability or tension or difficulty with bringing support to your organs, as well as maintaining continence. And if it gets really tight, it can cause pain with penetration. And then this is the deeper layer, and I like this slide because it shows you how it's a nice hammock or sling. And it's going from those pubic bones all the way back to that tailbone area and back up, kind of this nice horseshoe shape. And then it fans out to meet our hip muscles. And here's the hip muscle. It meets the obturator internus. So our hips and our pelvic floor are really closely interconnected. Weakness or tightness in our hips can create imbalances in our pelvic floor and vice versa. And so really it's that interplay between not just your pelvic floor, but your hips, your pelvic floor, and your core, which we're going to learn about later. And so here we go. So if we look deeper into our pelvic floor, so if we have a model, oftentimes we have a little model that you may see when you go to therapy, and it's got some organs in it. Let's see if I can do this without it blurring. Oh, maybe not. Okay. These muscles, when we think about the pelvic floor, your levator ani muscles, but look at this, check this out. It goes all the way to the front of the back and then connects up into your diaphragm. And so this is really interesting because your pelvic floor and your diaphragm work together as you're breathing and exerting. So, and even these hip flexors. So when we talk about back pain, difficulty breathing, incontinence, constipation, it's not just the pelvic floor that we're looking at in physical therapy. We're looking at how the whole trunk moves together to support your trunk and your pelvis. And this slide over here explains this nice canister connection between your pelvic floor going front to back, side to side, your back muscle is called your multifidi, and then this diaphragm connecting to your abdominal wall. So with pregnancy, the abdominal wall is stretching and expanding 115%, really down here a lot. And then with delivery, your pelvic floor is stretching up to 3.5 times its length. No other muscle in your body is able to do that. So that's a lot of stress and strain on these muscles. And up to 1 out of 10 women will have significant damage to their pelvic floor if they have vaginal delivery. And C-sections too will have damage to these muscles because they have to go through 7 different layers when they take the baby out. So our job is to manage this intra-abdominal pressure. So if we see, this may not work with this Zoom thing. But anyway, this balloon represents this intra-abdominal pressure. So if it was sitting inside the abdominal cavity here, and we inhale, the pelvic floor down here relaxes as you inhale, and as you exhale, it comes back to rest. If we were to kind of suck our breath in and hold it or pull our tummies in really tight, that pressure goes down, and a nice responsive pelvic floor will meet that pressure and tighten. And sometimes what happens is it creates too much tension, and then your pelvic floor shortens and gets tight and weak. And so we want to make sure that we have that full range of motion so that we can respond to stress and pressure, like when we go hachoo or cough, cough. So we have enough range of motion and tensile strength to manage that intra-abdominal pressure. So a lot of our core exercises in education with lifting children, getting in and out of bed, lifting car seats, strollers, is managing that intra-abdominal pressure so that we don't put excessive force on the pelvic floor or our backs, or if we have a diastasis, that tear in the front, as well as building enough strength and resiliency to return to exercise. And we'll talk about that later in the talk. Okay, so we went over that integrated core, that idea of using your pelvic floor, your core, and your diaphragm together. And one of the things that we teach right away is how to breathe. So when we inhale, the diaphragm contracts, the lungs fill with air,
Emily,
abdomen and your pelvic
I don't know
floor.
if it might be my end, but you were dropping out a little.
Oh, sorry. Can you hear me now?
Yes, I can.
Okay, thanks for letting me know. Okay, so I'll just backtrack about that integrated core. So when we inhale, our diaphragm contracts and air comes into the lungs, our abdomen expands and our pelvic floor relaxes. And then as we exhale, that's when we force the air out of the lungs. And so that's when we're going to be using and activating our pelvic floor and our core. So a lot of our transitions, lifting, carrying, getting up off the floor, and then eventually weightlifting is going to be done on the exhale. And we go over that a lot in therapy when we're trying to retrain that core system. And then just a little bit about the bladder, mainly to highlight when you're pregnant. I don't know if this is in the way or not, but when you're pregnant, here's the uterus sitting over the bladder. So when you have to go to the bathroom constantly, that's just because there's that big pressure right over the bladder. But also to note that the pelvic floor is a nice stopper here right at the urethra. And the urethra is only about 4 centimeters long, so it's really short. So that pelvic floor control when we're pregnant is really challenged because not only is it getting stressed and strained, but then you've got that nice baby pushing down on it. And then afterwards, those muscles have lengthened. And so anytime a muscle lengthens, it can become weaker. So incontinence is common, but not normal, but it is very common, especially in those first 12 weeks after delivery. And then another cool thing about this slide is, again, you can see that clitoris right here. And what's neat, what we're finding in research is that along the urethra, there is some tissue that is found to be very similar to the prostate, which has some contractile properties, as well as can be seen as an erogenous zone, so it can give pleasure. So perhaps that's the mysterious G spot that we're all searching for. But that's how there's the connection between pleasure and intravaginal stimulation. Okay, so what happens when down there after we have baby? What's going on? How are we going to fix it? So we're going to review some common but not normal problems that occur after having baby. We'll review some bladder health information. Oftentimes we get leakage or simply urgency and frequency. The same can occur with bowel health, especially if we have a grade 4 tear, where we can have fecal incontinence and excessive urgency, like we can't get there in time, as well as constipation, especially early after postpartum, especially if you have any pain medication. Sexual health, intimacy can be painful. We can have low desire due to changes in our hormones, as well as just being sleepy. And abdominal strength. Do we have that diastasis recti? How do we measure that? What does that mean? Also there's orthopedic considerations like joint pain, SI pain, low back pain, and when simply can you return to exercise? These are common questions that we have. So we'll talk about the bladder first. I'm just going to move my picture. And one of the most common ones is stress urinary incontinence. And in fact, folks that have a vaginal delivery will have a higher likelihood of having stress incontinence. And what that means is when we have an increase in intra-abdominal pressure that the pelvic floor can't overcome. So you see in this, right, the abdomen increases pressure, pushes pressure on the bladder, and then you get leakage. So this is common with cough, sneeze, strain, run, jump, hop, skip. Urge incontinence is typically due when the bladder spasms, and that's typically due to maybe feeling anxious or nervous, or maybe you're drinking a lot of sparkly waters, alcohol, sodas. There are common bladder irritants that can contribute to the bladder spasming, and that really responds to some bladder retraining. And we can go over that here. And so some healthy tips to keep your bladder healthy is drink plenty of water, especially in the early postpartum stage. If you're breastfeeding, you're going to need a lot of water because you're producing breast milk as well as hydrating yourself. Time voiding. So oftentimes when we are young, or even as a mother teaching our children, we'll say, go to the bathroom just in case we're leaving the house. Go to the bathroom. We have a meeting, so you better go just in case. Go to the bathroom. We're getting in the car. So that just in case voiding can create a habit for your bladder to empty when it's not completely full. So oftentimes we put the bladder on a schedule to increase the time. Normal time between voids is anywhere between 2 and 4 hours. If we're going excessively, it can disrupt our day and cause leakage and nocturia or nighttime voiding. When we want to avoid caffeinated drinks, including sodas, coffees, and teas, which can irritate the bladder. Building pelvic floor strength is needed. Staying active is really helpful for the bladder, as well as some breathing exercises and maintaining a healthy weight. And speaking of healthy weight, bowel movements are can put a lot of strain, and constipation in particular can put a lot of strain on the pelvic floor. And just like delivering a baby, the pelvic floor has to expand and relax and lengthen to have a bowel movement. If we squeeze and try to push down, that can create increased pressure on your pelvic floor and actually cause the bladder to press into the backside of the vagina, which is a rectocele. So oftentimes we can put our feet up on a step stool to relax that puborectalis muscle, which has to open and lengthen to have your bowel movement. And then we drink plenty of water, exercise, and that's where coffee can actually be a good thing. So warm fluids or a little bit of coffee can help stimulate your bowels. And of course, eating a nice high fiber diet is important as well. Another thing that can happen after childbirth, I don't know if my picture's in the way, but it's distracting me, is what's called pelvic organ prolapse. And there's some big risk factors. Having multiple pregnancies in children increases your risk factor for pelvic organ prolapse. Instrument-assisted delivery, especially with forceps. And so the research is saying that if they do need an instrument to pull the baby out, that the vacuum causes less damage than the forceps. And then the second stage of labor where you're pushing, that's really prolonged, like 90 minutes or longer, that's another risk factor. Of course, a large baby's head, and then constipation or like a persistent cough as you get older can contribute to organ prolapse. And organ prolapse is named by the organ that is falling into the vagina. So a common one is cystocele, because again, remember that uterus is pushing down on the bladder. And that just means that the bladder is kind of falling into the front of the vagina or the anterior wall. A rectocele is where the bottom part of the rectum protrudes. And sometimes people have to splint with their thumb to have a bowel movement. The uterus can fall down. An enterocele is the parts of your small intestine can come down, or the vagina, the actual back part of the vagina can just droop down. So there are lots of things that physical therapy can do to help this, and they're graded on a scale of 1 to 4. If you're a grade 4, it feels like this little chicken, like your eggs falling out. I don't know if you can see that. That's surgery. And generally speaking, that occurs in older people or if you've had a lot of children. But anything between a grade 1 and 3, physical therapy or conservative management can really help. And sometimes we just need to throw our legs up on the wall and give ourselves a break. But seriously, putting your legs up on the wall can help with managing pelvic pressure from organ prolapse, as well as managing that intra-abdominal pressure and strengthening those muscles in your core. And sometimes a passive support is needed, like in the shape of a pessary. And these come in many different sizes and shapes. Young women can learn how to insert them and take them in and out for sport or activity. They do need to be removed for menstruation or intimacy. Older women can leave them in if they're no longer sexually active. They can leave them up for three months. They go back to the doctor takes it out, cleans it, and puts it back in. So it's a quite handy device. Okay, what happens with bedroom activity after baby? There's a lot of reasons why returning to intimacy can be a problem for folks. If we have a scar, whether that be a C-section or a episiotomy scar, things hurt down there. They're sensitive. Your sensation has changed. How things look and feel might make it difficult. Hormone changes. So after 3 days of delivering that baby, your hormones are really high during pregnancy. In 3 days, boom, they drop. That is a lot of crazy changes in how you're feeling, in your mood, causes vaginal dryness because the estrogen drops as you increase the hormones to produce lactation. We're tired, we get cranky, we have a new baby. All of those things can contribute to lack of desire. Pelvic floor muscles can feel too tight. They can feel weak. It just feels different. And that can be difficult for people to get used to. Joint pains, our back hurts, our hips hurt. We can't touch our toes anymore. Maybe the position that you like doesn't feel good anymore. And so you're not quite sure where to start or begin. And again, we're often just really tired. And we have a new baby to take care of. So let's talk a little about scars. So C-section scars typically run transverse from iliobone to iliobone. And a lot of people will state that it doesn't feel like a part of their body anymore. They feel separate from it, that one section might feel a little numb. that there's a change in sensation, that it feels kind of rigid and not the same, or that it just looks different. And so oftentimes we educate about desensitization, integrating it back into your body, and then some gentle scar massage so that you can feel comfortable with touch around that area. Because just like we said, right below that scar is going to be that mons pubis in the beginning of the vulva, and the clitoris isn't too far away. For folks that have vaginal delivery, oftentimes we can get tearing or episiotomy, which is episiotomy by definition is a grade 3. Grade 1 is just a little tear, it can be anywhere in this area, or even sometimes people get it up towards the urethra. And it's just superficial. They may or may not even use a stitch. Grade 2 is going to involve some muscle tearing in the perineum. Grade 3 will go all the way through the muscles into a little bit of the external anal sphincter. And grade 4 goes all the way to the sphincter. And these are pretty large tears going actually inside the vaginal canal as well, requiring many stitches and takes a while for healing. There's a lot of pressure, sensitivity, and could even involve some nerve changes. So you have to be gentle. What do? We need to moisturize that area. So that vulvar area is skin that's sensitive. And just like we put special lotions on our face, we can do the same thing in the vulvar area. So if this is our clitoris and the urethra is there and the vaginal opening, all of this area is where we're going to moisturize. So you can use non-hormonal creams and lubricants, balms, Aquaphor, lidocaine for numbing, hydrolonic acid compounds are really nice for hydrating, and you can use them daily to many times a week. And then also things you can put intravaginally if bad, like inside dryness and you don't want to use an estrogen cream. There are many over-the-counter products now that are great that either have like a little applicator that you squirt in there or like a little suppository that you use twice a week and it just dissolves and moisturizes from the inside out that's non-hormonal. And so we'll often educate folks about how to keep that skin because we need things to stretch and move so that we can have penetration and also for comfort and support of the organs. And then we can start some scar massage after about 6 weeks when that tissue is healed. We can use fingers in the area. We can use, so you can use your finger or your partner's finger. You can use 1 digit. You could use 2 digits. You can use your thumb to stretch in there in the shower or in bed. Or oftentimes we'll teach people how to use like a wand or a vibrator. And the vibration feels really good in that perineum and in the scar to work that area to desensitize and also to bring blood flow to the area to help that tissue move and to take fear out of touching that area again, to reintegrate it back into your body and your brain map. And so we can start that around 6 weeks postpartum or so. And then in pelvic floor therapy, we teach people about muscles. So if muscles are tight or tender, we can use like the wand that I showed you or dilators to gently stretch and have tolerance to how that tissue can move again so that it can be comfortable to accommodate your partner. And so these are examples of different dilators. They start really small, like the size of my pinky, and get all the way up to the size of your partner. There's silicone-based ones, there's plastic ones with handles, and then there's so many different options for vibration therapy as well. What happens with pregnancy and if your abdominal wall stretches and if you get a little tear in that connective tissue, that is called a diastasis recti. And that is this fascial tissue right down the center that sometimes tears. And oftentimes that's determined in the growth of the baby, how big the baby is, and then purely your genetics, how much the tissue is able to accommodate stretch. It can be central, kind of near the umbilicus or the belly button. It can be below. It can be above, it could be the whole thing. And so in therapy, we'll measure that to determine how big, if you have it, how wide and how deep, and then how we can take care of that. And kind of that fun fact is that abdominal wall stretches 115% by that 38 weeks of pregnancy. So that's a pretty big stretch it has to overcome. So imagine if your tissues stretch like taffy, then you deliver a baby. They're not going to recoil. I mean, there is some elasticity to our tissues, but they're not going to instantly go back to that flat ab that you had, before a baby. So we have to give our body time to gently recoil back. And sometimes, like if you stretch, ooh, I've got a rubber band. If you stretch a rubber band and you stretch it all the way, it doesn't recoil back. So sometimes that happens with our muscular tissue as well. So we may have some permanent changes there. So rebuilding that core strength is something that we do. And again, we talked about integrating the pelvic floor and the core and your breathing diaphragm together so that we can maximize this core canister so that you can move your arms and limbs effectively and not put strain on your back or your organs. So there's lots of different ways to do core strength. And I'm going to talk about some, obviously we do that in therapy, but also some online systems you can use. So before, when we gave this talk before COVID, there were no guidelines on what to do after physical therapy, or sorry, after baby. And the biggest thing was the American Gynecology and Obstetric Association said at 6 weeks, you can return to exercise, go for it. And obviously women, not everyone was ready to do that. And so in recent times, there's been some articles, they're still not completely peer reviewed, but there are at least some guidelines for return to exercise safely and effectively. And what we're finding is really that 12-week, that 3 months is when we can really start to effectively go to more impact exercise. So those first few weeks, we want to really focus on keeping that perceived exertion anywhere between a 0 and a 2. So really lightweight movements. That means maybe walking, maybe just 10 minutes inside the house, eventually at 4 weeks going outside, in your neighborhood, doing some gentle breathing exercises at the beginning and focusing on flexibility and mobility, and really spending time with your infant and your family. You can begin strengthening isometrically your lower abdomen and pelvic floor, and really working on postural strength. So back muscles, glutes, because you are lifting and loading as you lift your infant, depending on how big they are. So it's not like you're laying in bed all the time, which brings me to this common principle that people are online going, oh, you need to do the 5-5-5 principle. 5 days in bed under the covers with your baby, 5 days on top of the bed, dressing, but really just staying in bed, and then 5 days engaging with your family inside the house. And the research does not really support that. Yes, you want bonding, you want rest. We do need rest as much as possible. But what we found for postpartum depression and general health is that early mobility, gentle walking, breathing exercises, engaging your core, interacting with folks is actually better for your overall physical health and mental health. So that doesn't say that if cultural reasons you want to bond with your child, skin to skin contact is really important for bonding. You can still do that, but we don't encourage bed rest unless it's required by your physician. So just be cautious with what you read online and what the current trends are. But the literature supports safe, low exertion movement for both mental and physical health. Okay, what about after that 12 weeks? So once we reach 12 weeks, any scars have healed, you have a good schedule, typically with your infant, you're getting maybe not more sleep, but you have a routine and a rhythm. You may be dialing in on your breastfeeding, or perhaps you've weaned by then, depending on how your infant and you decide to do that. And now we have a screen for when you're ready to go back to impact, which we'll go over that in the next slide. But we screen you through about 5 or 8 different exercises to see if your body can hold that load without any pain, without any leakage, and with good control. In this phase, where we're going to build core strength, glute strength, we're going to gradually return you to impact, whether that be running or burn boot camp, or just being able to jump around with your toddler. It's important to time, if you are breastfeeding, to time your impact exercises around lactation. This can be cumbersome for new moms, but certainly you don't want to go out with a full breast and go do some jogging or jump roping. That wouldn't feel good. Generally speaking, the research supports weight training or strengthening twice a week. In general fitness, we should be aiming for at least 3 or more days a week. Still incorporating your rest. Rest is really important. So you are busy, perhaps at this point you're going back to work as well. And maybe instead of doing a high impact exercise, you do something like lower impact, like walking, swimming, Pilates, or yoga. And recreation is also really important. Sometimes in our American culture, we forget about recreation. That might be, pickleball or going for a easy hike or bird watching, painting. Activities like that are equally as important as physical fitness. And just to briefly go over this new screen, this is excellent. As therapists, we can really give patients concrete examples and goals to attain. But you need to be able to walk 30 minutes without any pain, pressure, or leakage. Be able to stand on one leg for 30 seconds and also do a single leg squat, which is kind of hard for folks. Jog in place for a minute and do some hops, as well as hop in place for a minute, and then this balance exercise that we do that challenges more dynamic work. Another thing to test yourself is, can you stand on one leg and go up and down and do a heel raise? You need to be able to do that 10 times. As well as another test is, can you sit to stand out of your chair on one leg? That really tests your core, your glutes. A lot of people can't do that even if they haven't had a child. And of course, in pelvic floor therapy, we're going to be looking at your pelvic floor strength and endurance to see that you can handle load. Because if you go to impact exercises like running, the ground, so when your foot hits the ground, that's called ground reaction force, and it can be 2.5 times your body weight. So that's a lot of force on those organs and muscles. And so we want to make sure that your muscles can support that impact. All right. Where do you go? What do you do? So you can go to your local gym. And there's lots of different online programs. The Peloton has one now, is what folks tell me. There's one called Mama Strong, Birth Fit, Moo2 system's been around for a long time. Get Mom Strong and Mommy Fitness. These are just a few online systems. There's also YouTube has free videos that you can get. Of course, seeing a pelvic floor therapist can be really beneficial as well, to help guide you through your return to activity. All right, thank you for listening. I am going to stop the recording and then